Hello, everybody. Thank you for tuning in today, and welcome to our midday download, which is an abbreviated web series to give you a concentrated amount of information. Today's session is going to be slightly longer than some of our other downloads because we've got lots of fun regulatory stuff to go through. We'll be clocking in at about an hour, but I've got some insightful observations and some good recommendations for you, so hang in there. This month is extremely cool for my colleagues and I. It's Provider Directory Data Improvement Month. If you're involved with Provider Directory Data Improvement, this is your time to demonstrate your unique knowledge and value that you bring to your health plan. Also, I've declared that the official pastry of Provider Directory Month is the cheesecake. So please consider that. From the registration list, it appears that there are a lot of healthcare organizations with small provider networks that want to discuss methods for cleaning up their directory. So we'll be sure to provide you guys with some really good tools to be able to do that. And hopefully the information today is going to be valuable. So let's go ahead and get started. A little bit of housekeeping. If you have questions, feel free to use the questions panel on the bottom right-hand screen of your GoToWebinar application. And FYI, today's session will be recorded. All attendees will receive a link to view the on-demand webinar. So feel free to forward that to your friends and colleagues. Hopefully it'll be useful to them as well. And your phones will be muted upon entry and during the webinar. Okay, so a little bit about who we are at CAQH. CAQH is a not-for-profit alliance of health plans and health plan trade associations. We work collaboratively to create shared solutions to reduce administrative burden across a number of different healthcare business use cases. So our board, that's all of the guys up here, all of their logos, that's our membership. It consists of these health plans and trade associations, and they're our chief collaborators. They help us identify some of the biggest pain points in the industry between business processes among plans and providers, and they provide us with great ideas and input on our solution development. But in addition to these board members here, we also have broad reach and market penetration with over 1,000 participating health plans, hospitals, and other types of organizations, and 1.6 million unique healthcare providers participating as well. So that's who we are and who we serve. And before we get started into the actual content, I want to learn a little bit more about who we have on the line here. And I guess for you guys, you can learn a little bit more about each other as well. So I have a couple of polling questions. And the first one is, what methods has your organization used to improve provider directory accuracy in the past year? All right, well, let's take a look at your guys' responses. So, what's interesting is we've actually done this polling question a few times over the past years. It's always interesting to see how this response compares with previous years. And what we've heard from plans is that health plans really have a desire to reduce their phone and fax outreach. However, it looks like you guys are still doing a considerable amount of it. It makes sense. I mean, that is what CMS is doing, as we'll get into some more detail about in terms of auditing directory accuracy. So it makes sense that you guys would continue to want to do things the way some of the regulators are doing it. But still, we have a growing number of folks who are using either a health plan portal or analytics-based approaches too. So we'll go into some details in the upcoming content about how you guys are using these interventions. Let's go to the second polling question, which is a piggyback off of the first one. So, of the interventions that you've been applying, how impactful are these interventions? Has your accuracy decreased? Has it not changed at all? Or has it increased maybe 10 or 20% or more? Let's share the results. So as you guys can see, there's a little bit of a distribution here. So barely anybody has actually had accuracy decrease. Maybe we've got one response like that. Seems like 33%, so about a third of you, haven't seen any significant change in accuracy. And then others have seen more modest improvements in accuracy. Maybe a couple of plans have gotten 20% or more, but mostly it's either not changed at all or pretty modest improvements, 10, 20%. So that's good to know. Okay, so we're going to get into the kind of the core part of the webinar right now, where we're going to review our recent 5-year history of federal rules around provider directories. And for many of you guys, this is going to be review, and this was a review for me as I was preparing for this webinar. However, it's really interesting to see the old regulations, all the way from 2016 onward, in sequence and in context with the developments that have been going on in industry and some of the activities you guys have been doing. So, in the spirit of Provider Directory Improvement Month, it is great to be able to acknowledge the progress that you guys have made, but realize that still there's a lot of work to be done, as we can see in some of the polling that we just did recently. So let's take a look at this timeline. This is going to be a roadmap for today as we're going through the last several years of directory. So let's start back in 2016. So if you remember, the Affordable Care Act at 2016 was about 6 years old because ACA came out in 2010. And after ACA, there was an influx of new beneficiaries getting care for the first time through some of these exchange plans. In addition, before 2016, right before 2016, there was a seminal study in JAMA Dermatology about provider directory accuracy. And they did some of their own audits and showed that directories were really, really inaccurate, and it was actually having a negative impact on patient access to care. So CMS decided to take action, and they took action across all of the federally funded lines of business. So you've got Medicare Advantage here at the top, you've got QHP, the exchange plans, and then you've got Medicaid and CHIP around the MCOs. So on the Medicare Advantage side, the one kind of provision here is the regular ongoing communication to the providers. But there are a lot of other impactful provisions as well. There is the $25,000 per error per beneficiary affected. So it gives CMS an option to enforce compliance around these new directory rules. On the QHP plan side, so this middle box, there's a 30-day update requirement, but in addition to that, there's requiring these exchange plans to publish their directory information via machine-readable JSON format. So that was a new thing for them. And then for Medicaid and CHIP, the update requirements were even more stringent. So 3 days after data receipt, plans had to update their directories. So this was kind of the big bang moment in 2016 that started all of these new activities around provider directory across the plans. All this experimentation, CAQH did its own product launches, there were partnerships, AHIP was doing some pilot work, and of course there is the monitoring by the federal government, which if we go to the next slide, we'll dig into some more details of that. So your eyes aren't fooling you, there's a graph here without any bars on it. So what that means is that in 2016, CMS had not yet started its auditing of Medicare Advantage directories. So we'll continue to update this as we kind of go along the time continuum. So we talked about the ongoing communication to providers. So CMS had this idea, and I think this was a natural idea at the time, that if we could just let providers know, nudge them a little bit that information was being used for health plan directories, maybe that was our ticket to getting directories more up to date. It's just communication. It wasn't a bad hypothesis at the time because many providers were not updating their directory information with health plans. So the nudge and the communication was a good first step at that. However, the second bullet point is interesting because it's giving CMS the ability to work through contractors to audit health plan directories and see how accurate they were, and they called it monitoring at the time, but they were pretty much audits. So just to give you some background about what CAQH was doing at this time. So when the directory regs first came out, CAQH worked with its health plans to launch its direct assure solution, and at the time everybody was kind of focused on the quarterly outreach requirement. And so CAQH similarly was focusing its direct assure solution on quarterly outreach, but it was built on top of the ProView platform with the 1.6 million healthcare providers, trying to give them as much of an easy way as possible to submit directory information. So in the middle of 2016, CMS started auditing health plan directories. So 54 MA plans got audited between February and August 2016. So what the audits were, just for context, CMS had a contractor make phone calls to over 100 directory entries for each health plan and ask questions to these practices who were picking up the phone saying, could a patient make an appointment with a provider at this address? So these weren't exactly secret shopper methods, but they were meant to assimilate the experience of a patient or a beneficiary trying to find care. And so, in January of 2017, we all got our first audit report as an industry that revealed the actual nature of the directory accuracy problem. And what it revealed was that on average, MA plans directories were around 55% accurate. So that means that if for an average Medicare Advantage beneficiary, if they were to select a provider from a health plan's directory, around half the time they wouldn't be able to get the care they were seeking because the directories were so inaccurate. And a large part of that, as identified by CMS, if you look at that third bullet here, a majority of the errors were that the provider was not practicing at location. So CMS observed this, and then they said, it looks like groups are just reporting every single location for every single provider. And so, of course, there's the quote here is an inflated number of locations for provider. That's kind of the big, massive problem within directories. CAQH saw that and said, okay, hey, we're going to make a hard turn in terms of our solutions and really focus on this dimension of the problem, see if we can make some progress around that. So this is a little bit more of the same. Another year, another round of audits. The second audit report came out in January of 2018, so just a year after the first one. And health plans during this time, they were continuing to do their outreach. They're experimenting with other methods. Some had begun using CAQH's new directory reconciliation capabilities and receiving boosts in accuracy. AHIP had given its report by this time on their pilot collaboration that they'd done with 2 vendors, and they had some interesting findings there about needing to incorporate provider interaction and also promoting collaboration in the industry. And then CMS, many other plans were just trying to see if CMS was going to change its direction or see what solution methods were going to work out the best. So what we saw was that the accuracy pretty much persisted at the same level. So, just around 50% accurate. So no significant change or improvement in accuracy, even with interventions in the aggregate across industry. The other thing that CMS observed is that many plans weren't using their own auditing. They weren't auditing or testing their own data. And CAQH has observed a similar thing that when plans audit and test their data, they've got a better chance at improving it because they'll know what interventions work versus not. So we do echo CMS's observation recommendations there. So that was an interesting finding as well. But then the second bullet point here is the 23 notices of noncompliance and the warning letters and warning letters for business plan. The other interesting thing that CMS recognized here, the last bullet, the centralized approach, and they were even more emphatic in 2018 than they were in the previous report, said the centralized approach would make data collection verification more efficient. So this makes sense. If providers have one place to deposit their data and health plans have one place to pick it up, that reduces all the chasing of the information and gives the industry one place to verify the information and cleanse it. So it makes a lot of sense what CMS is saying here. So let's take a look at 2019. It's becoming a little bit of Groundhog Day in 2019. Deficiency rates are persisting, requirements are persisting in the midst of all of this. There's a tidal wave of state regulations that are emerging as well. CMS continues to make similar observations in its annual report as with previous reports. So let's go to they continue to make the notices of noncompliance and the warning letters, and they say yet again, that there are no significant changes in data accuracy. They do call out very explicitly this time active participation and engagement by providers is important for accuracy, and they double down on their observation about the centralized repository. They say that there are network economies there. If you can correct the data in one place, multiple Medicare Advantage plans can benefit from it. And so what's interesting is in 2018 and 2019, CAQH has had the opportunity to brief CMS on its own efforts. And we recognize that we share this interest in rationalizing or reducing the number of channels by which providers are submitting their directory information. We're both philosophically in agreement on centralized repository. I think the question about which centralized repository is kind of the standing one. And so CMS had inquired about CAQH, hey, could we quantify the burden that providers and plans are experiencing in the face of these channels? So let's go to the next slide. So CAQH used this as an opportunity to conduct a study in 2019 to assess the economic burden of directory outreach, updates, and verification to providers. So we surveyed over 1,000 physicians and their staff, as you can see on the left box there. And we asked them how much time they're spending per month to respond to directory updates. And we got some good kind of salary compensation information for different types of team members on their staff. And then so through this study, we estimated that over $2.65 billion in economic costs are being incurred by providers on an annual basis due to the fragmented nature of these directory updates. So it's a huge chunk of healthcare spend. Of course, we've heard all of the grief that the healthcare industry is getting about physician burnout, and of course, you guys as plans know that provider satisfaction in your network is an important part of your network quality, and it's taking time away from staff to focus on care. So it's of course likely going to have an impact on directory accuracy as well. Okay, so let's fast forward to today. This is February 2020. I can't believe it's already February of this year, almost March actually. So here are the things to report. So no audit report was published in 2019. We do have some indicators through the grapevine that CMS may be renewing its auditing again in 2020, but we haven't verified these reports with CMS. So those are just kind of discussion points that we've heard. There's a NPRM stands for Notice of Proposed Rulemaking. This was actually a proposed rule by CMS in 2019 for interoperability. You're probably asking, well, Ron, what the heck does interoperability have to do with provider directories? Interesting that you ask. So the interoperability rule is actually targeting federally funded health plans, so plans with government-funded lines of business, so Medicare Advantage, Medicaid MCOs, the exchange plans, potentially imposing requirements to those plans to open up APIs for consumer access. So for consumers or beneficiaries to be able to get access to their information from the plans. But in addition to that, being able to get directory information via APIs from the plans as well. Now, these interoperability rules have never affected plans in this significant of a way. Just for you guys' information, the final rule is not yet out. So people think that it's probably going to come out in the March timeframe when the big HIMSS show comes out, but we're not sure yet. But that could be a significant thing, and it piggybacks off of the old 2016 requirement by the QHP plans to publish the machine-readable data. So all that to say that directory information may be mandated to be exposed via API by these plans. And finally, and this is probably on your guys' mind, for those of you who have Medicare Advantage business, you probably received a memo from CMS on NPES and on some of the experiments that they're doing with NPES and updates that they've made to the system. CMS seems to be trying to see if there's going to be uptake from plans and providers to utilize NPES for directory updates. So this is actually the same graph as before, so there's not a new bar there. But still, CMS continues to say that accuracy hasn't improved in the past 3 years. They continue to emphasize the need for a centralized repository or source of truth. And this is where things get interesting because while CMS and CAQH agree on the philosophy of a centralized source of truth, CMS seems to be indicating that NPES may be considered as an update channel for directory information. And of course, there's the NPRM for the API activities as well. So, if you guys are interested in engaging with CAQH more on, what we're finding on the regulatory front and how, potentially our offerings can help you guys out there, feel free to reach out to us. We'd be happy to talk. All of this to say that, as you can see in the bar graphs and the reports from CMS, progress in the aggregate industry has been slow. And CMS recognizes the need to rationalize channels for directory updates and outreach. It just makes sense. If you can reduce the number of channels, then you have a better chance at more efficiently getting more accurate information. With that being said, some plans have been able to leverage pre-existing provider-friendly sources of truth that are being used by a majority of providers within the industry to significantly improve their directory accuracy. Some of these offerings are from CAQH, and I want to walk you through them. And these approaches can provide plans with immediate compliance relief, minimize the risk of regulatory warnings and notices of noncompliance and the rest. All right, so what I'm going to do over this next section is walk you through 2 case studies by 2 different plans who are utilizing the Directory solution. This first health plan is a national health plan, and within this case study, they managed a targeted effort using Directory within a specific market. So just a recap of the capabilities of Directory, because I think I described it a little bit at the beginning of this webinar, but it doesn't help to reiterate. So Direct-Assure builds on top of the ProView platform. The ProView platform is used probably by most of you guys to capture credentialing information for your health plans. It's used by 1.6 million healthcare providers. 1 million of these guys are coming in every 120 days. So we've got really, really good engagement. All provider types: physician, NPs, physician assistants, genetic counselors, athletic trainers. Really runs the gamut. So what Direct-Assure does is it takes directory information from the health plan, and then it brings it into ProView, and it compares it against the data that the providers have reported, and then identifies where it's different. And then when it's different, it asks the provider to make a judgment call on the difference. So in this case, this national health plan launched Direct-Assure within a Texas market across 19,600 providers. And then, of course, each provider has multiple practice locations. So in total, it's 60,000 provider locations were brought into ProView. And then let me explain the math here. So we've got 43% of the locations that were submitted by the health plan match data within ProView. So that gives the health plan a level of confidence that, okay, it matches the data that the providers reported in CAQH, probably a good address. 57% of locations didn't match. We're going to need to make it go through this workflow to get providers to respond to it. So, as a callback to our regulatory discussions, of course, CMS says provider interaction is important and is key in improving directory accuracy. So let's move to the next one. 57%, that's the same number as you saw in the previous slide of the locations not listed within CAQH. And here's the breakdown of the ones that are listed. So the 63% of those locations were actually rejected by the provider. And we'll go into a breakdown of that in just a second. But what that means is that providers are saying, hey, I don't practice there, or I no longer practice there. You should just not publish that within your directory. That's a known bad address that you should just take out of your directory. 21% is I don't know. There's some multi-affiliation scenarios in there where you've got staff members who are providing responses. But we did sample audits around the I don't knows, and 70% of the I don't knows should not be displayed for directory use case. So plans are making different judgment calls on that. Some of them are being really aggressive and just removing all of them out in their directories. Some of them are queuing them up for research and for further audit. And then 16%, so a small minority, are accepting the address, which gives the health plan confidence that while CAQH didn't have this address, the provider accepted it within CAQH. And so, I can keep that within my directory. And this is the breakdown of the rejected. So let's just skip to the bottom, the 55%. So 55% of those the provider saying, hey, I no longer practice here. So I practiced there once. I'm not practicing there anymore. Remove it from your directory. I recognize this address. So, it's good metadata that this is a bad address. And, most plans are just willing to automate that right away. But you've got a mix of other reasons too, like I never practice here, it was entered by mistake, or I never practice here, it's part of my group. So in that case, you can keep it as part of the claim system, but remove it from your directory. So we've got a lot of good business rules. So if you guys are interested in engaging with us, we can really help explain to you how other plans have implemented and really walk you through how you would implement it on your side based on kind of your risk tolerance. What we're showing here is that, of the locations that were submitted, 26%, or sorry, of the locations within the directory, 26% of them can be removed. So that's just a big chunk of bad data that is suddenly just extracted and removed out of a health plan's directory. 73% response rate within 120 days. That's totally explained by providers are already coming into ProView on a regular basis. We've got the 1 million providers coming to ProView every 120 days. So it's just really easy for them to respond to these types of questions within their workflow. So all that to say is scalable method, and it improves accuracy pretty quickly for a health plan. I'm not going to go through all of these suggested business rules, but all we're trying to capture here is that health plans have been able to take our responses and do a combination of automation and manual workup of specific scenarios. Of course, we want to automate as much as possible to be able to reduce the lift on your guys' end. However, there are some cases, especially around some of the I don't know responses and some of the uncertain cases where manual additional audits and workup are necessary, especially when there's contract implications like a brand new TIN or a removed TIN from a provider profile. So we are happy to advise you guys on these business rules as well. We've seen 50 different implementations, so we've seen quite a different range of risk tolerance, and we can help you kind of custom fit it to what your particular plan's needs are. So this is a health plan that similarly has deployed direct ashore, I think actually within the same market. So this is interesting because they're piggybacking off of the efforts of the first plan. But let's get into the actual content. So this health plan decided to use direct ashore, the same capabilities, so taking the location data from the plan and reconciling it with a provider in Texas. And they were really impressed with some of the proof points that fulfill their requirements. So the number of years CAQH has been in the space, our reputation among the provider community, our ability to capture the range of information that they're looking for, including all of this professional directory information. But the important point is that they were able to piggyback off of the work done by the first health plan, because the first health plan submitted their data and got all these responses. But CAQH doesn't forget those responses. We actually hold on to the suppresses, because if a provider has rejected location, so if Dr. Leslie is saying I don't practice at 123 Main Street, that response is true for every single health plan in the industry. So we hold on to that. So if health plan 2 submits 123 Main Street for Dr. Leslie, we're going to give you that response right away. So that's what's really cool about that, is because we've had 50 health plans that have gone through this effort already. If you're a new health plan taking advantage of it, you can take advantage of this like inventory of bad and good responses immediately. So it just really speeds up your ability to get good, actionable information into your provider data management system. Okay, so let's take a little bit closer look at the solution. This is a little bit more of a detailed workflow and of what I've described before. So all this is saying that health plan is sending directory information to us. We're comparing it. So that kind of the cycle arrows at the top, comparing against data submitted by the providers, and we're reconciling it. And then we're asking the provider to make a judgment call on it, and then providing it back to you guys for processing. So it's just a workflow that represents that. So, positive results here, just like you saw in the previous case study. So we were able to, with its 25,000 providers, around a 3+ month period, and we were able to get 84% of providers within that period to respond. 69% of the locations had actionable reconciliation responses. 32,000 locations submitted. And here's kind of the benefits here. 60% of locations were identified as valid. So that means the health plan can confidently keep those within their directory. But then 40% of locations were identified as invalid. So that's a big chunk of their directory that was in error that they can just start removing, and now they've got a higher quality directory. So pretty good responses, and we're able to get those volume of responses within that time because we're piggybacking off of previous efforts. What else is this health plan doing to make sure that their directories remain accurate? Well, they're, like I mentioned, from the CMS recommendations, they are auditing their data as well as CAQH's data just to make sure that the accuracy levels remain at the appropriate level. They're doing very targeted provider outreach. They're using not just us, but some other vendors to supplement. So we play nicely with other guys if you so choose. And they were able to automate a very significant amount of their directory updates using a lot of the business rules that we had recommended and using all of the metadata that we have. So a lot of really good tactics there that they've been able to employ. Let me just wrap all of this up. I gave you guys a short history of the regulatory activity and the evolution of CMS's perspective alongside the industry efforts. And we collectively better understand the root causes of the directory problem. And of course, CAQH feels like it's got a really good solution to give you guys immediate relief on cleaning up your directories using our foundation of portal that's being used by 1.6 million healthcare providers, and some of these demonstrated success stories. So, I just encourage your health plan to consider the DirectorSure solution. Please reach out to others who've used it. We want you guys to really hear it from the horse's mouth, if you will, that this is a successful solution for your peer organizations. And feel free to reach out to me and others within CAQH to get your questions answered and to learn more about the solution. So I appreciate everybody's time today. And we look forward to hearing from you. Thanks for joining us on the Midday Download.